The average age of the women that seek treatment in my office is somewhere between 38 and 42. It seems like that's when women seem to notice something that's different, that they can't quite put a finger on, that they've sought treatment for someone for, and they've either been put on an antidepressant, they've been put on something to help them lose a couple pounds, or they've been referred to a psychologist or a sleep doctor or all of the above. And they frankly just get very dissatisfied, and I don't know how they come to arrive at our door, but they come in seeking something. And if you just let them, and we do a 90-minute consultation, so if you just kind of just not talk for a while, which is sometimes hard for me to do, but if I just not talk and let them just talk, they tend to just kind of relay a syndrome that is almost word for word exactly the same if you just give them an opportunity. So that's how I know it is a syndrome, and I think women deserve better than what they receive currently. And I think it requires events like this in order for people to hear the right information so they can make the right decisions that's in the best interest of them. And we call that collaborative decision making. And in the past, medicine, something I feel very firmly about, that medicine is not very collaborative. Frequently, doctors tell you what you think you should do. It's very dictatorial. It's the way I was taught. In the ER world, oftentimes you do have to talk to people in that manner, because if they don't do what you suggest, they're going to die. But in this world, it is very personalized, and people have different journeys, and they do need to know the risks, the benefits, the treatment options, the context, what they're trying to achieve, what type of lifestyle they want to have now, next week, next month, in 10 years, 20 years, 30 years, 40 years. And it does require a very collaborative approach to your health. So without further ado, I'm going to introduce Laura. She's going to come up. I think most of you know Miss Laura, Dr. Laura Justice. Laura, I think you'll do a good job. She had introduced me last time, and now I get to return the favor. So Laura, take the floor.
And I'm going to bring Ashley up right now. Thank you all. I'm going to bring Ashley up right now because I think what we want to start is kind of like giving us a little background, kind of where we are in our personal journeys. So for those of you who do not know, John did a great job. Thank you, John, so much. And I kind of did force him into this space only because I went through almost full-blown menopause at a very early age. So I kind of started getting symptoms really early, like 37 or 38, and then it progressed into significant symptoms right around the age of 40. And at that time, which would be 23 years ago, there was nothing out, and certainly not in Lexington, Kentucky. So I kind of, being a little bit of a nerd in the medical sphere, I started researching a lot and finding out that in the larger cities like New York and Chicago, there were some things that were happening, and mainly prompted by Suzanne Summers, who wrote a book with a lot of physicians about things that she was experiencing, and she was vocal enough and famous enough to write a book and talk about it. And I think she even said it was like the 7 dwarfs of menopause. It was really very informative because it was mostly written by doctors. And she and by reading that, I got resources that then made me actually fly to these places to seek help. And the reason I did it is I went to my medical doctor, who did blood work, and he didn't know what he was doing, but he did blood work because I told him to. And I said, I need you to do blood work on my hormones because I think something's really wrong with me. And he did, and he said, your testosterone is 0. He goes, now, I don't know very much about testosterone, but I think you're supposed to have some. That's what he basically said. And he said, but you have 0. It's 0. And he said, I honestly don't even know who to refer you to help you with this. And that kind of led me on the journey, because I knew I needed some level of testosterone in my body. I didn't know what. And sadly, I never had known what my normal levels were. So I had never done blood work to know what baseline levels. And when I say that, everybody's different and everybody's baseline's different because we all have different body types, so we have different levels of hormones. And I've learned a lot of this. So a lot of my knowledge, unlike Dr. Mullins is empirical. It's just me experiencing feelings, knowing that this wasn't right, and then doing research and trying to find out answers. So that's kind of where I'm coming from, is a little bit more empirical. I just happen to be a dentist, which helps me a little bit, almost harmful in a way because you get a little too medical, but that's kind of where I came from and what created my journey, and we'll talk more about it. Now, Ashley has a different journey because she's in a different place. I'm now 63, so I've been 23 years in.
Well, I'm 45, and I will be 46 on July 15th, actually. So for me personally, the first thing that I noticed, and I say noticed because I think these symptoms, sometimes we didn't have a lot of education or knowledge about the symptoms of perimenopause, and now you can get on social media, you hear about it all the time, so there's a lot more information out there. But one of the first symptoms that I experienced was waking up at 2 o'clock in the morning. This started around 42 for me. And I would wake up and my brain would start going, and I'd lay there for 2 hours and I couldn't go back to sleep. And there wasn't really anything specific that I was stressed about. It was just and it was almost like a rhythm. It'd be, every other night, and then it'd be every night. And it was just constant. And I'm at an age now and then that I needed sleep. And I think we all need sleep, anyway, but especially in your 40s. And so for me, that was something that I noticed. And at first I thought, well, it's anxiety. So I need to go to a doctor. I need to get put on an antidepressant or whatever. And I'm not knocking antidepressants. I think they're great. But like Laura was saying, I kind of wanted to investigate it a little bit more and research it more. And it just so happened that at the time I was dating John, and I told him what was going on, and he kind of dove into it a little bit more with me and was like, nope, this is what I think you're going through. And turns out it was. And I'm still going through it. So it's just, and it really is interesting, because when you do start to research it, it becomes more interesting. And I feel like you want to know more about your body and the way your brain is changing and the way your body's changing. And as women, our bodies, honestly, from the day we come into the world, are so different from men's. And dare I say this, but I think a lot of women have been treated the same way men have been treated in the medical world for a long time. And we're not wired the same way.
Question.
Sure.
So the insomnia,
Yeah.
any tips?
Well, for me personally, I am now taking something called progesterone. And it's how many milligrams?
Are you taking it pill form? Or
I am taking it pill form. I take it days 12 through 26 of my cycle. And it is not like a sleeping pill, okay? It's to me, it gives you kind of just a zen feeling, like you even out. And so for me, that's helped tremendously. I also take a magnesium supplement at night as well, and that's helped.
Do you take estrogen with it or not?
If you're cycling, sometimes you don't. It depends on your cycle and where you are in your journey. So if you're still having cycles, that would be a John, Dr. Miller thing about when to add. I don't know.
Typically, when you're still ovulating, which is in the perimenopausal world, your hormones are starting to change, and that's what's causing a lot of the symptoms. It's not like you can check your blood and see it, because it's a continuum over the entire month. So I want to also just mention real quickly, if anybody just said they've checked your blood and it looks normal, there's no way they could say that. Maybe they do look normal, but you can't. It doesn't mean anything to check your levels other than to confirm that you are still ovulating. That's all
Correct.
you can really check. And to Laura's point about testosterone, the reference range is arbitrary. The range of normal is 2 to 45. And I guess if you're 1, you're abnormal, or 0 in your case, you're abnormal. So it really doesn't mean a whole lot but it's an age-related hormonal decline or fluctuating decline that occurs that culminates in weird symptoms. But sleep is one of the biggest ones that women present with, and it's a relative progesterone deficiency. Relative to the amount that you once made, relative to the amount of estrogen that you're currently making, and that balance is what causes insomnia in women. The reason we give it on days 12 through 26, our goal is not to suppress you from ovulating. We want you to continue to make estrogen for your bone density and such. And if you tracked yourself with one of those little fancy trackers, you would most likely notice that your sleep is worse during that period of time on days 12 through 26. Day 1 is the first day of your period. You count 12 days and you count the next, and that is where you typically will notice that your sleep is worse. And so we try to correspond with adding extra progesterone during that period of relative deficiency. And for women, a lot of times that is a game changer, because it'll allow them to sleep, and it alleviates their brain fog, and it alleviates some of their anxiety symptoms that they're experiencing.
And one of the things I'll say this, because it's really, like, for me to try to make people aware. When you're young, I really highly recommend, so if you have young people, and that doesn't necessarily, I mean, when I say young, 25 to 30, go get all your blood work done so you have a baseline, because the baseline helps, if you have that, to know where you're going to be when you get to perimenopause and menopause, because then you can kind of have where you were when you were in your prime, because again, we're different. All of our body types are different. So where you lived in a testosterone, progesterone, all of those levels are different. So just like John's alluding to, just because someone might be at a 50 level of testosterone and they don't feel the same effects as someone you can't, that's the hard part about hormones. And that's why how you feel is so significant, which you do the blood work to kind of see, but really a lot of this is about talking about how do you feel? How do you feel about, how are you sleeping? How does, what's your sex drive like? All of that. So it is, and look, again, we're talking about this being a syndrome because it starts with little tiny changes, and it can start early in the mid-30s, and then it goes to where Ashley is, and she said those things, and now she's saying the sleep thing, which I think is a big one, the sleep thing. But then, the transition into the full blown can take a long time. Perimenopause can last a long, long time. And I was one of those people, and I'll tell you why, that went into full blown menopause fast, is because I had adrenal fatigue and adrenal insufficiency. And if and John and Dr. Miller can talk about this, when your adrenal glands are blown out, it really affects all the other hormones significantly. And then all those changes happen at kind of like a warp speed. And so, and there's a lot of people who have different syndromes, whether it be Addison's or Hashimoto's or different things with thyroid, but the thyroid is also controlled by the adrenals. So I'm just saying, this isn't easy. This is not an easy thing, but the fact that we're talking about it and that we're going to interchange about what we're doing is the key to getting help. And you cannot, and I'm going to say this right now, you cannot expect to be an overnight fix either. It's kind of like you do some things and you see how you're feeling, and then you do some other things and see how you're feeling. Would you agree?
Absolutely. And it also means you have to take personal responsibility. So, eating habits, some things that I've had to change. I used to have a glass of wine or maybe even 2 right before bedtime. Well, I know now that if I do that, I'm not going to sleep. So it's either I do that and I don't sleep well, or I decide to drink my magnesium instead and sleep well, which is usually the case now. So
Somebody had another question. Yes, Isabel.
So for the past 14 years, I've either been pregnant or had an IUD in. I have no idea what is happening to my body because I haven't had a period in 14 years, which I think is glorious. And I don't want to change that. But how do I know if I'm in perimenopause or...
You should be able to tell from your blood work. it'll still say if your LH or FSH is high or low, even with an IUD.
Okay, I'm going to say this at the end, but I'll say it now because we're having good questions. What I'm going to tell you is these guys know because this is their area of
You
focus.
won't know unless you have your
You-
blood checked if you're not having active periods.
Correct.
How old are
And
you?
39. I'll be 40 in September.
So you should still be ovulating, obviously. They didn't suppress your ovulation. And if you're on like a marina,
Yes.
so you have a progesterone only IUD that's locally acting, it won't affect the rest of your systemic use. So you should be doing okay. I mean, you should still be ovulating even if you're not having periods. Can you not tell when you ovulate?
I
You don't
I've
have
not
symptoms?
had nothing. I mean, I feel like I'm a psycho person.
that would be a symptom.
Crazy.
But that would be your symptom, and you know when it's occurring. I tell you what, you could still wear a ring. It might help you, but I will tell you, those symptoms are your symptom of when your cycle would be.
I have to actually remove my ring because it's about to fall off. Because it's like my finger's skinnier. And then other times that I can wear a ring. Is that what you mean?
No, well, what I'm just saying is to kind of give you an idea of possibly when you might be ovulating. Like
A lot of people that you're in the age group where you would start to have perimenopausal symptoms. It may not happen to you at 39. It may not happen to you.
Till
Some of the ones that
50.
People come in, it's just brain fog.
I have friends,
I
yeah.
don't know how you define brain fog, but people that have it know that. Or I used to work out, and I used to be able to notice lean muscle mass if I worked out hard. Or I used to go on a diet for 2 weeks before I went to the beach, and it would just I could get rid of this, and now I can't. And it's very subtle. It's like things that are just different.
So an IUD doesn't hide symptoms because you're not having a period.
All it's doing is working locally for you not to have a period or to not
ovulate.
It's not doing anything systemically.
But don't you think your hormones just, like, looking back over my long life, I think my hormones changed after I had kids. Before I was in any sort of perimenopause or premenopause or anything. Like, after I had kids, it's almost like the chemistry completely changed. And I don't know what studies have been done on that whatsoever, because, I mean, there's got to be a difference between having a kid at 15 and having a kid at 30.
Well, I think the longer I do this job, the more I realize our hormones control everything.
They do.
So they don't work in isolation, and they don't work in isolation for men. It's not like testosterone just makes men have high libido it's God's no dummy. And those things intertwine with everything that we do, all the different metabolic functions that we have in our body. And they do way more than just control our periods or control a man's libido. They do way more than that. And the fact that we've actually made it sound like that's all it does, because they've almost really condensed it into that type of world. And just as a little statistic, the average amount of training an OBGYN has in the world of perimenopause or menopause during their 5-year residency training is 6 hours. So it's not their fault that they don't know either. I certainly wasn't taught. The only reason I do know is because I've done this now 10 years, and anybody that hasn't immersed themselves into it, you really have to go looking. You have to be your own
Do
advocate.
they provide that training for any
No.
medical field?
No, zero.
No.
No,
Because they don't
endocrinology
have
gets
it, or
zero,
they just
urology
provide-
gets zero.
I'm going to tell you,
OBGYN makes
I'm going to tell you because I've been to them all,
Yeah,
zero.
yeah.
I'm going to say, and I'm not knocking it because that's how they're trained. So you have to actually seek out extra training to have knowledge. So not to say there's not OBGYNs or endocrinologists or any of these or urologists that aren't seeking out, because they are. At this point, they are. So there are people who have realized there's a problem that they didn't learn what they needed to learn. And, you're seeing them on Instagram now, and you're seeing them out there, and they're becoming famous because of it, because there's so few of them that have gotten specialized training in this. And I'm glad, because it's making the world more aware. Think about this. 23 years ago, nobody was talking about this.
23 years ago. 23 years ago was when the World Health Organization published their 2001 study related to the use of estrogen in the context of women's menopause symptoms and how it contributed to breast cancer.
Well, yeah, I had a question. So, So I'm 63, and I've been told for the last 7 or 8 years,
That's too
no,
late.
too late. You're
Yeah.
too late.
That's been
Sorry,
completely
I'm so
debunked.
sorry.
That's supposed to be individualized. You're a very healthy person. I can just tell by looking at you, you have very low risk of heart disease just by looking at you. You have to make an individual decision. It's personalized. You can't just put everybody into a bucket and say that anybody that's been 10 years post-menopause should not entertain hormone replacement. We have plenty of them in my practice that we start in their 70s.
Okay, I have a question. Okay, when you said you're taking progesterone,
Mhm.
why do you? Okay, because I'm doing the cream. So what's the difference between the patch, the cream, and the pill?
Well, I can tell you the main reason people like the pill is because immediate release, and they get the benefit of having a high level at nighttime because it really helps with their sleep.
Okay.
You can take progesterone during the day, and you can't really take unopposed estrogen if you still have your uterus. So you can take progesterone for that purpose, but you won't get the benefit of sleep because you can't achieve high enough levels in your blood with a
So
cream.
with that cream, I know,
You
like
can't.
I'm rubbing that cream on every night.
So-
and I'm really,
so-
like,
So when
I'm just like,
when I've seen OBGYNs combine progesterone, estrogen, testosterone, and you're not going to get the benefit of what progesterone does for you,
what about the
Megan.
patch?
neither. You
Okay.
need a bolus. You need a rapid onset, high peak level, and then it precipitates sleep. We have a standard panel that we do that is, that you'll have standard things like where you check kidney function, liver function, urinalysis, CBC, and things of that nature. When it comes to hormones, we do a detailed thyroid panel, not just a TSH. We do LH, FSH. We check their estrogen, their progesterone, their testosterone, their sex hormone binding globulin, their prolactin level, their iron level, and a variety of other things that we check just because a lot of people that come to us are interested in longevity. And there are some longevity markers that people need to know are one way or the other so they can plan accordingly. And this is something I want to take home. When you know you're going to live a long time, your strategy should be different. And medicine is reactive. So everything is geared towards people that are sick. There's a lot of healthy people in this room that I can tell are going to live a long time. You should definitely plan accordingly if you don't want the last 20 years to be in a nursing home.
Mm-hmm.
In osteoporosis, with Alzheimer's, with a hip fracture, with heart disease. And so these are the kind of things when I'm talking to patients, I was like, I can tell you're going to live a long time. Your blood work, your lifestyle, the way you take care of yourself, the way you dress, you live a vibrant lifestyle. I can tell you're going to live a long time. Your strategy will be different than this person who is the opposite. And you should plan accordingly. And hormones should play a vital role in that.
I'd also like to add that labs are not gospel.
No.
They add context to your
Yes.
symptoms. So
It's really, as Dr. Miller, I never say good news, your labs are normal. That doesn't mean anything. It can give me a little bit of information. Majority of what we do when we're talking to people, we're just kind of like what we're doing right now.
It's a,
I
yeah.
call it kind of shooting the shit. We're just kind of talking. And it takes a long time with a provider to where a person will open up and talk. It takes more than 5 minutes. Our consults are 90 minutes because it takes a long time to develop rapport with people. So anyway, I don't mean to hijack your thing. I just want to keep going.
No, I like it because this is the thing, and Dr. Miller, you're right. That's the thing is it's a baseline, and that's why I'm saying the younger you can get a baseline on some of those sex hormones, like not in just all of the hormone levels, really. It's just a baseline for where you're going because now and look, when you're full blown, it's harder to figure out what your levels are. We can get there, and we've done that, and I've been able to do that successfully. But John's so right. All of this plays into longevity, and I will tell you, nobody was talking about this 23 years ago. I knew I was taking a risk. John mentioned the WHI study, and every single person, including every doctor I talked to, told me I was crazy because I was going to get breast cancer from taking these hormones. They did. They told me that. And I said, I'm going to take the risk because I'd rather feel better than like I did feel. And I knew I had every single one of these symptoms. Almost every single one of those were pretty much me. It was really bad. And I didn't want to feel like that anymore. So I was my own advocate, going to feel like that I was traveling on a different journey. I think now, if I'd only kept all the data, if I just kept the data of 23 years of being on bioidentical hormone replacement therapy. And I want to make sure we know the difference. There's hormone replacement therapy, which is often confused with bioidentical hormone replacement therapy. So, these are just debunking the menopause myths about menopause means the end of your whole sex life, which it kind of did for me, I'll be honest with you. That was the number one symptom, was like it was an overnight change. Like I had no desire for sex. And that was my number one change. And that's why I got all those levels done. But once you get on hormone replacement therapy and you kind of start normalizing, that all can return and you can have as great a sex life in your 60s as you did in your 30s. And that's a for sure. So I want to make sure we all know that. Then that it's not a disease, but it is a syndrome, and it's pretty much an evolution. We're there, we're going through it, and we just want to do it. It's a biological thing, but we can do it with, and it can be improved with supplementation. HRT is dangerous, and this is the WHI finding, which was, John alluded to, said if you're taking estrogen, it's definitely going to be, and it was such a misled study because it was done with, number one, they used 62 and older women to do their study. They did it with chemical hormones, which was progestins, which were produced by pharmaceuticals. A lot of you might know about the Premarin patches and some of the progestins, and those were some of the things that they were studying, and it's all been debunked. And what we found is actually a lot of these things actually make a significant difference and can actually decrease your chances of cancer. I'm going out on a limb on that one. I don't know if there's enough on that.
That's true. Testosterone alone reduces a woman's risk of breast cancer 50%. So it's not like 1% or 0.1%. It reduces a woman's risk 50% of developing breast cancer. And bioidentical estrogen and progesterone have never shown increased risk of cancer whatsoever.
Never.
And in fact, I would say there's probably 10% of the women that are in my practice have had breast cancer already.
Well,
Been treated.
I was a lab rat.
Yeah.
I had hormone positive cancer for a long time. I was on estrogen suppressors. And then, my life was falling apart at that point because hormones really do control
Your
how
life.
you feel about your existence. So when I wanted to have hormone replacement therapy, they would only do testosterone on me for years. And it was only maybe 7 or so odd years ago that I was put on an estrogen replacement as well. And it's made such a difference in my life. But the first thing they started with was my thyroid, and then worked from there. But this is after I absolutely refused to take estrogen blockers anymore.
Well, again, women have to be their own advocates. I mean, again, a woman should be able to make her own decisions based upon the risk-benefit profile that's effective, that pertains to them.
But doctors scare you. That's the problem. And it's just because they haven't done the research. And the research, and Laura, you
I
just...
had to bring my research in
Correct.
to my Mayo doctor
Yeah,
to
you
say.
basically have to do that.
Yeah, and I mean, a Mayo doctor, let's say that. A Mayo doctor. Isn't that sad? I'm just telling you. So this is why I encourage everyone to at least have a consultation with Dr. Miller and Dr. Mullins, because I just believe there's a lot of myths and a lot of misconceptions that are absolutely not true. And everybody is individual, so I'm not going to say this, that I don't know what your prescription will be, but I do know that bioidentical estrogen and progesterone and testosterone do not promote cancer.
They may not know exactly what you're saying about So you get a birth control pill. That's a synthetic birth control pill, synthetic estrogen, synthetic progestins. Those absolutely do have an increased risk of breast cancer. You've been taking them since you're 18 years old.
Correct.
And many women take them postmenopausally to control their symptoms, even though there's absolutely 100% they've been linked to an increased risk of breast cancer.
Yeah, you should not be on any kind of birth control.
Bioidentical look exactly the same as your body's natural production of the hormones, and they absolutely are not linked to any increased risk of any cancer whatsoever. And it's as if probably up until about 100 years ago, men and women weren't even biologically living much longer than 50 anyway. These are really kind of new issues. I guess these are a sign of the times that we're actually able to even have these discussions. But if a person's going to live to be a centurion, and I think there's women in this room that will be, these are discussions you would need to have with someone and do your own independent research. And as she was mentioning, you have to come in armed with your own information to have an intelligent conversation, and many times you'll be more versed on the topic than the doctor you're talking to, and they find that embarrassing. But at the same time, they do know that they're underprepared to have these discussions.
But I would highly encourage anybody who's already kind of halfway through menopause to discontinue birth control.
Including an IUD?
IUDs are perfect.
IUD is the only birth control I'm okay with.
Yeah.
I wouldn't even let my daughter be on birth control, you guys. I would not. Let me just clarify what I'm saying here. Because I had started this in an early journey and my daughter was young, I would not allow her to be on birth control pills ever. I wanted her to do the IUD and the IUD only, because it operates in a different fashion. Birth control pills, I think, and this is just me empirically saying this, and I've had a lot of conversations with people that I respect that I think are way more knowledgeable than me. I think birth control has been a major significant contributor to breast cancer.
I think alcohol has too. I think that's probably my reason.
I don't know. I almost 100% believe it's the birth control pill. If you go tracking and you do the data and the research, when birth control started and you go prior to that, you don't see tons of breast cancer before birth control. No. You don't.
That's true.
So.
What's your next slide there, Laura?
Oh, it was probably something funny. I always try to incorporate. Oh, no. This is just talking about HRT. And when I say HRT, I'm a proponent of bioidentical hormones. I know there's a lot of people online that'll talk about other things. You can do a lot of things. But I'm more of a proponent of the bioidentical ones that mimic, it's like the bottom one. And that's what Ashley's on too. She's doing progesterone, and she's probably doing a pretty low dose. But again, you're either going to be estrogen only, and that, I guess if you don't have a uterus or ovaries or anything, you'd be maybe an estrogen only. If you still have your uterus and ovaries, you'd be an estrogen progesterone. It just depends on, and delivery systems, pills, patch, gels, creams, pellets. Mm-hmm. I think I do have I don't, and this is, John and Dr. Miller, pellets are easy for a lot of women because you don't have to think about taking things. And so you can get your estrogen and your testosterone in a pellet. And depending on what stage you're in, by the way. So everybody's here is going to be in different stages, so it's not going to be the same for everybody. But you can do the pellet. You can do creams. I do think the progesterone pill at night is the way to go. I don't think the cream's the right answer for progesterone. I do think you can do estrogen and testosterone cream if you're diligent and programmed. I do think for most people having the pellet is the easiest way because you don't have to think about it.
But I heard it was hard to control the amount. I don't know anything
Not
about
on the pellets. The hardest thing to control is the creams.
Oh.
Because there's a concept called variable absorption. Even in the same person, if you take the same medicine and then you change skincare products, or the compounding pharmacy decides to change their recipe a little bit, I end up chasing my tail more with creams than I do with anything.
And I'll tell you, because I'm going to be honest about everything I do. I asked John to take me off the pellet only because I was battling a little bit of estrogen variations. And I didn't want to be too estrogen dominant, and I tended to be that way. And I felt like that with the pellet, my estrogen, I felt like it wasn't as easy. So I wanted to do the cream to try to see if it would do. But again, we have looked at my levels just to make sure. Like he's right, blood doesn't tell you everything, but it seems like that it's working. But if it doesn't, I'll go back on the pellets. I've done pellets, so I've done everything. And if you want to know all the things I do, I'll talk about it, and Ashley can talk about what she does too.
Well, I was going to mention something. This is something I started recently. How many,
Oh,
and you don't have to raise your hand on this, but how many of you have experienced urinary tract infections? Recurrent urinary tract infections. Okay. So if you have, I was getting them twice a month for the last year. And I couldn't figure out why. I was like, there's something wrong with me, or I've got cancer, or just it's going to be something horrible. I know. Well, so it turns out that when you are going through perimenopause and menopause, and you can probably explain this better, but I started doing the local estrogen cream. Now, I am not on an estrogen pill because I have not stopped my periods. I'm still having regular periods, but I am doing an estrogen cream that is an insert. It's kind of like, I'm just going to get out there, but it's like when you have a yeast infection, the cream that you use and insert, it's the same type of thing. So it's local estrogen, and I have not had a UTI since, which if you've ever had one of those, they're absolutely miserable. I think I'd rather have the flu. And I was getting them just repeatedly. And so, yeah.
And just to go one step further and be honest, because John knows this because we've been dealing with it. So you can get urinary tract, but then it goes into your kidneys, which is what happens with me. And then you get these pyelonephritis, which is uber dangerous. And again, doing the vaginal estrogen is locally is as a help, but there's tricks to actually help you with that too. But that is one of the major things that will occur with vaginal dryness. And there's some other answers that you can utilize for that, but it is not something, and it's dangerous, to be honest.
Yeah,
with
very
you.
dangerous.
I've tried hyaluronic acid vaginal suppositories, which I think work great, and Premarin, which works for vaginal dryness, UTIs, and I actually think it helps with constipation. I don't know what it is. This is me anecdotally. I can tell you that has helped with a lot of the shit going on.
Okay.
Now, are you taking magnesium at night?
I don't, because I try to keep what I take
To a minimum? I will say magnesium citrate is probably your best friend when it comes to regularity, and it helps you sleep. So that is
just, what was it, 2 months ago gave me progesterone, because I don't have my uterus anymore, so I'd never even thought that I needed to take progesterone, but I'll take it and I will sleep.
well, that will help you sleep, even if you don't. Yeah, I mean, like that's a doc thing, because that's not necessarily. Everybody's different, so that's not necessarily necessary. But if it works,
Oh my goodness, yeah, it does. It knocks me out.
okay. Other I want to hear. Yeah,
Does anybody ever use lysine
lysine.
for sleep?
I actually take lysine every night as well. Like if I told you all the things I took, now I take lysine because it is a great suppressant for the herpes virus as well, a natural suppressant. Now, John, I'm getting on a left field, but it does. And if you have herpes simplex or you get herpes lesions, like that really does make a difference, just keeping you loaded with lysine. Now, I did not know that it's helping you sleep.
TikTok.
Okay. But look, I take it at night for a different reason, but yay. Maybe that's why I can sleep so well. I mean,
I were a woman, I had trouble sleeping, or I had a woman saying 38 plus, or I had anxiety, and I mean, I bet most people in this room have anxiety of some sort. It is the most natural anti-anxiety medication there is.
What,
And
lysine?
No, progesterone.
Oh, yeah.
Progesterone.
no progesterone. Lysine, no.
Weight gain with too much progesterone.
You have to take a lot of it, which is why we always start really low. I've seen people come into our clinic that are on 4 times the amount that we start with. Most people need very little progesterone, 100 milligrams, no more.
Yeah.
Very rarely do we need more than that, and those are just when we're trying to balance their estrogen. But yeah, progesterone at nighttime, it really allows people. You know, our sleep is regulated by hormones. I mean, melatonin, growth hormone, progesterone. These are all things that are hormonally driven. The reason we sleep the way we do, God, in His infinite wisdom, gave us these hormones to allow these things to happen. And as we get older, we have less of them. And we I like giving back what we had before as opposed to giving something different, like Ambien, Xanax.
And that's why, and longevity,
Lexapro, this and that and the other.
and that's why in longevity, it's so, like, anybody that's talking about longevity and doesn't want to incorporate hormones isn't really, like, to me, like, it's just like, no, you can't leave hormones out of longevity.
Body to not produce hormones in an older age. Why did he do that? You know?
Well, we live longer than we ever have before.
Well-
we
Lived to under 20 in the beginning of life.
yeah, I know.
It's true, and if I could dig deep to God's brain, I think He allowed that for to be honest, for us to have to populate. So I do think, you know, the man controlled a lot of things. But if we're talking about all bodily functions, if you have decline of hormones, there's an increase in cardiovascular disease, joint disease. I mean, you name it. All the diseases of deterioration occur when the hormones go down.
And to your point, Stark, because I hear this one a lot, is if a woman knew that taking hormone replacement therapy postmenopausally reduced her risk of having a heart attack 50%, or she could take a statin that increases her risk of having Alzheimer's 30%, we don't have any problem as doctors prescribing statins that we know cause problems, and then that we're having a debate whether or not something that's more natural would prevent it. If we knew that your risk of Alzheimer's disease goes down 50% if you take hormones versus not, would you want to be in a nursing home? And I'm telling you, there's a whole generation of women after 2001 that are now in nursing homes with Alzheimer's, heart disease, and hip fractures that were deprived of hormone replacement because they were scared to death that they caused breast cancer, and they weren't even afforded the opportunity. And my mother died from Alzheimer's in a nursing home, and I watched the whole demise thing happening. And I'm telling you, and when I was in high school, I worked in a nursing home. You just don't want to be in a nursing home in a diaper and have your faculties. And there's a lot of people that are going to live to be 100. You just don't want to be there at 80. Because I consider these things just completely natural, almost like supplements. These are just giving back what you had before. You just don't have them anymore.
Yeah. Well, that's the confusing thing for me. It's like, because I'm 51 and I've had 2 kids, and I never have been on any prescription, anything.
Yeah.
You know, I was on birth control, and then after my second child, I developed migraines from it. So then I got an IUD. And since then, the IUD has been great. Like, it was perfect. I didn't have any problems with it. But I've never been on anything prescription other than that.
Yeah.
So now I feel like it's just the fear of, like, what cocktail am I? You know what I mean? And it's like, I just hate feeling like
I
kind
hear
of like
that a lot. That's why we have meetings like this, because to me, I treat
I know
hormones
something's
and
changing.
supplements different than medications because they're different. Medications are used to treat chronic disease. People don't get better on. People aren't cured. I think there was a slide that said, "Is menopause a cure?" There is no cure for menopause. But hormones do what you just get you back to where you were previously and allow you to live a more vivacious life during the time you have left without feeling like you're taking medications. The medications will come.
Yeah,
You're not on hormones. You'll be on the next thing they'll do your bone density scan, and they'll say you have osteopenia. Let's put you on a bone density medication that has millions of side effects.
Oh, terrible.
Now you have heart disease, so let's put you on a statin, on a blood pressure med, and let's put you on this, that, and another. And then you have early cognitive decline, let's put you on Namenda, let's put you on this, let's put you on that. And those are the diseases that come with neglect and lifestyle neglect. And if there's a lot of people in this room that I can tell take care of themselves, and when you take care of yourself and then you incorporate a longevity type of plan that incorporates judicious use of hormones that's personalized for you.
Yeah, that's the thing. Like what you're talking is, that's a personal
It's not a
subscription.
one
just
size
now
fits
feeling
all
like I
thing.
need something, but I'm like, I'm not going to rush out. Like, that's why I want to.
No, I think you should go now and before it gets worse.
But you explore it, and you find somebody that'll allow you. opportunity to talk about it without, this isn't a sales job.
I mean, look, Christina's walking out the door. Don't walk out right now. Don't walk out. Because Christina's been talking about this, and Christina's young, but she was talking to him, and she's starting to have those experiences too, and she's wants to get on top of it, which I mean, that's the key, is doing it at a younger age is almost easier to manage than if you, I mean, we can manage it at any age, because it's a lie to say that it's not manageable. But I think the younger you do it and you get a concept of where you are, the better off you'll be.
Well, and so first I would like you to revisit the magnesium citrate, but you take, this case study. 55-year-old woman who 6 months ago had a hysterectomy in 2017, but I had an ovary, so I didn't know if I was in menopause or not until it hit really hard 6 months ago, and the night sweats and the hot flashes. Gained 20 pounds in 6 weeks and did absolutely nothing differently. And you can't get that weight off. And I'm going to be one of those octogenarians because my grandmother will be 102 next week.
I hear this.
So it's like, and I'm on estrogen replacement, but nothing is working, and you get discouraged.
But what's your
Very
estrogen replacement?
I'm on estradiol cream because of the vaginal dryness, so it's not
Local?
Yes.
Okay.
All they've done is kind of control a few of the symptoms,
Yeah.
but if
But
you,
it's how do you treat that whole person?
this is where you get into microdosing GLP-1s, testosterone to gain lean muscle mass.
Talk to me about
progesterone.
GLP-1s because we don't have any long-term studies with those.
Well, we have,
What's that going to be like in 10 years down the
I
road?
think that if you'd asked the same question about statins, they would have told you something different. I've prescribed them 4,000 or 5,000 times, and the more time that goes by, the more positive comes out of it for purposes of particularly in the setting of pre, para, and postmenopausal women.
He said
In the context
microdose.
of
That's
anti-inflammatory, the ability to become more insulin sensitive, which is another hormonal declining function.
very
Weight,
knowledgeable.
small amount of weight loss, but we're not using them for purposes of just profound weight loss, more for just get your metabolism to go back up. Testosterone to gain lean muscle mass, to burn more calories, lifestyle changes. It's really a combination. You layer all these things together, and there is a recipe for this. When I say there's a strategy for longevity, there is a strategy, but you have to do it all. You have to change lifestyle. You have to look at your risk factors, and you have to have preventive studies that are robust, just because we do all that kind of stuff. And you need to be aware of the risk-benefit profile. And frankly, if a woman knew the risk-benefit profile, it's less risk than most things you do already. There's more risk associated with taking Tylenol than there is about hormones. But Tylenol's over the counter. And I'm telling you, statins have more risk factors, and it's the #1 prescribed medication in the world. And they offer very little, if any, benefit to anybody, but yet they're prescribed like candy to everyone. And these kind of things, and I like the fact that we're even having this discussion, because these discussions need to be had by women, with women, because otherwise you guys are going to continue to be neglected. And neglect is the best way I can say it is. It is purely neglect. And there, I'm not a woman, so I can't say this much, but I've been around a lot of women. And there's usually one person that's loudest in the room, and they tend to have the biggest influence on the rest of the women around them. And I'm telling you, if that woman is the one that's an anti-hormone person, she'll influence negatively the lives of countless women before she leaves this earth, in a negative way. And I've just seen it. They walk in and they say, "My friend told me this," and they have been lambasted into this thing, and if they just did their own independent research, they realized that everything that she said was not true. It's not true.
Look at metformin.
Yes, ma'am.
When you're doing the HRT, how often should
I'm
you
already
get
on
your
it.
blood tested?
We
to
check it every
know?
4 months,
But I am allergic.
and we try to be consistent with when we're checking it, so that we can make determinations about we can. If we checked it at different times of each day, the results would be different. So we try to be consistent with that. And so what you're trying to do is you match symptoms with levels. You can't just go by either one. You can't just say your level is this, therefore you're fixed, because everyone's individualized. And There's been a lot of studies on that. We don't use, a lot of people don't even recommend checking levels per se. All you should go by is by symptomatology. If a woman feels good and she's at a higher level than somebody who feels good and they're at a lower level, that's just fine. And because they're safe.
Yeah, I'm 9 months into doing HRT, estrogen, progesterone, and testosterone. I don't really feel much different than I did
So the
all
endpoint,
throughout my 40s.
the
I had all
endpoint
issues.
for men and women have to be the same thing, is resolution of symptoms.
Right.
And the people that have the most symptoms are the ones that are most apt to seek treatment. That's the sad thing about it, because if somebody says I powered through menopause, well, for their own demise. Because if you don't have a lot of night sweats, hot flashes, brain fog, low libido, you'll just think you're doing dandy, so you'll just trudge on through. 10 years later, you have osteoporosis, you have your first hip fracture, you get hospitalized in a nursing home that you never leave, because 50% of people that have their first hip fracture die within 12 months.
I tried to, throughout my 40s, talk to various individuals about all those things you just said. I could not get it.
Well, there's a lot of, this is a fledgling industry that's coming out of the fog, so to speak, because there was
This
20,
conversation was had at that period of time as a system.
But it's going to benefit you, Melissa, I promise. Even if you don't think it is, it will. Even if you don't, like, because you may not have felt bad. You may not have felt that bad.
I just powered through and then I got over and didn't even know that I was.
and so one way that we do is we follow objective things like skeletal muscle mass, like we weigh people. So we want to make sure, if left untreated, a woman will lose 8% of her skeletal muscle mass every decade beginning at 40. And so we're trying to keep that from happening independent of their hot flashes, night sweats, because it's well established that skeletal muscle is the organ of longevity. The more you have, the longer you live. And it's not like you're trying to be bodybuilder size, but the more muscle you have, the longer you will live.
Do you feel like HRT plus diet plus exercise, are we looking at a full?
Yeah.
Yes.
Yes.
You have to control your macros. You have to do resistance training. You have to take protein powder. You have to
Lift
take
heavy.
creatine. You have to sleep 8 hours.
It's not, that's the
can't
thing.
piece it together.
It's not just one, like, I'll say this, all of us have to do those things. Diet, exercise, the right amount of protein, those are like the given for all of us. The levels and what we're taking depend on all of our basic body types and symptoms. But I mean, it just goes with common sense. You have to do resistance training. You have to be careful about your diet. You don't sugar is the enemy. Insulin. I mean, John's talking about these GLP-1s, microdosing them, because they're making a difference in your insulin sensitivity, and that matters for when you're in menopause. And they're great. And I do think, yes, there's not a ton of research, but the research that's been done is pretty significant.
Yeah, one of my patients is actually leading a research study at the University of Kentucky on GLP-1s and cardiovascular disease. And as a consequence of the study they're doing on cardiovascular, they're finding all the other things it's doing that are positive that are unexpected.
Right.
Treating inflammatory diseases like the Hashimoto's and inflammatory bowel disease and rheumatoid arthritis. They have a lot of really cool features independent of weight loss.
And dementia. Microdosing GLP-1s for
I want to say
dementia.
something real quick. I stepped out, so y'all might have addressed this, but I went to see my OBGYN 2 years ago when I thought I was starting perimenopause and talked to her about all my symptoms and everything. Her, right, and OBGYN, and I won't say what practice, but basically she said, do you know anything about how your mom experienced menopause? And I kind of knew a little bit. And in a roundabout way, she told me to power through. She said, I don't even think we need to test your hormones. If it gets worse or it gets this, come back. But like listening to all this now, it's just so crazy to hear the difference.
I don't know.
When I said that the average amount of training an OBGYN receives during their 5-year residency program is 6 hours.
Yeah. So it
And
was.
it's not their fault. That's how they were trained. Nobody else received any.
Yeah.
Nobody. So
Anyway, I don't want to power through, you know?
Like, is academia, are they like,
well, it's starting to change. Because the longevity space has started to change. If you haven't noticed, as people are starting to talk about how do we live longer, because when 74% of every healthcare dollar in the United States is spent on the management of chronic disease, that's an unsustainable situation. So now people are starting, how do we, instead of just waiting until people get sick, reacting to it, and then managing it until they die, how do we go about doing things that are preventative? And I'm telling you, the hormones are one of those things. Lifestyle, the reason we call our practice lifestyle medicine is because, first and foremost, it's the decisions you make, I make, they make, you make every day that determine ultimately how you'll do in life. But when you've maximized your lifestyle decision making, there's only so much you can do in that world. Then you have your genetics, epigenetics, and then you've got hormones that are just constantly, they're age declining mechanisms in our body. You need to add back to that in certain supplements that have been shown to be beneficial. And if you do that as a strategy, and when I say strategy, there's probably 10 things that need to be done simultaneously, people have fantastic results. And when people dabble on the periphery, they get dabbling results. And I see dabbling results a lot. Like, give me hormones, and I see a lot of guys. Give me some testosterone. Well, it's not going to overcome the fact that you need to lose 400 pounds and that you drink too much and that you can't sleep and you have sleep apnea. It's not going to fix that. If you think it's going to fix that, you're going to be waiting for a bit. But when guys take the position that they need to change their lifestyle, and they need to take ownership of their own decision making, testosterone plays a role in helping them. But it certainly doesn't fix the other stuff. And it's the same with women. Women, each decade has to be treated differently. The 30s, 40s, 50s, 60s, each one is different and has a different strategy.
Thank you for going past 50s.
Yeah.
Years, like.
Well, we have patients in our practice that are in almost 90 now that are still on hormones.
Wow.
And these are badass women that are still practicing full time, working, doing things, and traveling all over the world. I could name off 4 or 5 people off the top of my head, but HIPAA doesn't allow it.
So how is a bioidentical hormone not a chemical?
We're all made of chemicals.
Right.
It's when it says bioidentical, your body sees it exactly the same as when it made it itself. It's the same thing. Synthetics are not even remotely similar. Your body doesn't recognize it as similar, and it has unexpected side effects that are not common. If our own hormones cause cancer, then we wouldn't be alive as a species, right? But the ones that we've made artificially contribute to artificial issues. Therefore,
are they using yams for progesterone? Like, what are they using natural products to make bioidentical?
how are they making them? They sometimes use like some of them are derived from other animals.
Yeah.
But they're not synthetic, so they're derived by other animals. Yes. It's kind of similar to what's like desiccated thyroid versus synthetic synthroid. Sort of similar thing. It's desiccated, it's derived from a pig thyroid, but it is the same thyroid that humans have, just in a desiccated format that we give ourselves. And a lot of women and men do better with the bioidentical form of thyroid than they do with the synthetic version. And it's on a case-by-case basis. Anybody have any questions?
I've got a question. So I'm 45, I'll be 46 in a couple days as well. And so I've had some of the similar things. And the last year was the first time I had ever had a urinary tract infection. Had never had one in my entire life, and I've had 3 times in 1 year. And so anyways, I did a lot of research to figure out it was the change in the estrogen level. But a symptoms that I'm having, that I've been researching a lot about, is significant pain in my hips. And so I've always been a runner, and I would run miles and I would be fine. And I've recently noticed within the last year, because I started going, I'm still having my periods, but they're irregular. They've started to be irregular. But so I'm not on any estrogen replacement. I am on testosterone, and I do progesterone, and I do magnesium at night. And microdose. All those things, right? All those things that you do, and I feel great. I feel wonderful. But the pain in my hips, I've noticed that. And I've been doing a lot of research on that, and what I'm reading is about cortisol increases into so can you talk about that? Because I can find it, but I don't hear people talk about it. And I've changed shoes, and I've changed, all those things that they say, well, maybe the shoes, and it may be that, but my body's used to it, but now it's starting to hurt where I can't even lay down at night. Like if I get a mile in, I'm in pain.
Well, I mean, John's the expert, but I'm going to say this because that's cortisol is produced by the adrenal glands, and the adrenal glands are actually at the top of the chain that affect all the other hormones. And if you may be overdoing. You may, and that may be part of the problem because I'm experiencing similar things. I'm a high stress person. I'm constantly on the go, but when the cortisol levels are high, you do feel those things more, and that's I think it's one of the hardest things to control. So,
well, this
John,
joint thing is very common in perimenopause, and it's, imagine how a woman is able to give birth and their pelvis expand and allow them to deliver a child, and that's hormonally driven. So you think about what's happening when you start having relative deficiencies, slightly less estrogen than you had before. It won't show up in your blood work. You'd have to track it 24 hours a day. But sometimes in that case, we give a little bit of estrogen, not to suppress your periods, but just for that symptom. It does help for joint pain.
Okay. Yeah, and that's just been something I've noticed. Like all the other symptoms have been really, honestly, the testosterone's helped a lot.
Joint pain is a big one. Most women seek treatment at orthopedists and stuff for, they think they have arthritis. They think they have overuse syndromes, and they seek treatment. They get a variety of different x-rays, a lot of different imaging things, and they get put on NSAIDs to control their symptoms, and in reality it's completely hormonally driven.
Yeah, and it's very specific joints. I can tell it's very specific joints that I can feel it, not everywhere in my body.
Yeah, I hear that a lot.
I ended up going and getting stem cells because of joint pain. Now, that's a longevity solution. We're not talking about longevity stuff today, but I do think that some of it has to do with your personality and just where your adrenals and are you that person that's really kind of like on that level of just go, and so you're probably going to need more supplementation, and probably estrogen's going to help.
And I think that every person is different. The take home for me is I've been doing this for 10 years, and I wasn't expecting to have any of these conversations. It's every woman and every man, for that matter, that comes in is unique. And if you have 5 minutes to talk to somebody, you'll never see the uniqueness of each person, and they are unique. And in the context of hormones, it is really unique, and you have to really develop rapport with somebody. And the treatment plan is unique to each individual. Each one in this room, I've kind of scanned the room, probably would have a different treatment.
Yep.
And a different strategy depending on where they are in their particular area, and where they are in their life history and where they're wanting to go. And it has to be personalized, and it's not a one-size-fits-all thing. Not every woman gets a birth control pill, and not every woman needs this or that. Not everyone needs a pellet versus a cream. It needs to be personalized to the individual and their lifestyle and their travel history and their history of longevity, or the opposite is true. And it really, if you don't have somebody that's willing to have those kind of conversations with you, you're probably going to be treated in a one-size-fits-all format, and that will be good for the majority of people, but not necessarily for you.
I was going to say something, Tabitha, what you said. I used to be a runner long distance for a long time, and then I was younger than 42 or 45 for sure, but I was in my 30s and I started noticing joint pain, and I moved over to doing strictly weight training. And I'm not saying this is for everybody, but I barely do any cardio. And I have no joint pain. I'm, again, like he was saying, everybody's different. But I do think as women age, we need to focus more on weight training and building up muscle versus cardio. I think we've got it in our heads a lot that cardio. And sometimes that can cause impact on your knees and maybe your hips too, but that's helped me a lot. I'm not saying I don't know what you're.
Yeah, I do strength training 5
You
days.
do? Okay, well never mind, then you're good.
Strength training 5 days a week.
Okay.
But every now and then I just like to get out and run.
Yeah, I did too. I liked it a lot too.
I can just not think. I can just run.
Yeah.
And it feels good.
Yeah, it does.
Except
You're right.
at night.
Yeah.
It does. Yeah. I clean.
You had a question.
So about 6 months ago, my cholesterol level went up, and my doctor put me on a statin, and it got to the point where I was cramping in my legs so bad. So you're telling me the hormone replacement would Would it help my cholesterol as well as
Well,
giving
first
up
off,
statin?
and Dr. Morgan asked, cholesterol means nothing with your risk of developing heart disease. That would be the first thing.
Okay.
So you shouldn't even look at that as a variable in deciding whether or not you should start a statin medication. And that's just a flaw with the way we were trained.
Okay.
There's many other things that we should look at before initiating a statin in somebody that looks like you. I can tell by somebody in your family live a long time?
Yes.
Yes. So if I can tell by looking, then what are we really preventing? And then what is the risk benefit of taking something that has very little to validation as to whether or not it does anything? There's only a small subset of people that take statins that they've seen any benefit whatsoever. And those are people that have already had a heart attack. And when you study them for 10 years after they've had a heart attack, that group lived 4 days longer than the other group. Somebody like you, probably, we would look at your HDL, your ApoB, your Lipo-A, your insulin resistance score, your family history. I can imagine that you do not need that. I bet nobody in this room needs a statin.
Another question is, you mentioned melatonin. Are you a fan of melatonin? Or?
I'm a fan of melatonin if it works.
Okay.
But I found that it usually doesn't work unless somebody has a sleep cycle type of issue where they're going between time zones. I was an ER doctor 20 years. It didn't help me because it just didn't do it. Some people get benefit from it. I think that's good. Melatonin does decrease with age, just like growth hormone. And I think there's an argument to be had for using it. If it doesn't work, I wouldn't be surprised. There's things that I think are a little better than that. Even outside of the progesterone world, there's 5-HTP. There's some other things that seem to work a little bit better.
Okay. Thank you.
I have a question. What about frequent urination? Is this more a menopausal symptom or bladder weakness?
Like you feel like you can't empty your bladder, or you empty your bladder, but
That and its frequency as well.
I bet that you're having some issues with just the supporting structure of the tissue. The distance between a woman's outside world and their bladder is only about that far.
And I've had a hysterectomy as well.
Yeah, so when you get older, and our
Distance.
estrogen declines, that distance doesn't have any protection, so it just basically doesn't have a barrier any longer. That's why vaginal estrogen works so well, and not just for preventing UTIs or frequent urination. It works well with lubrication, less pain with intercourse. It makes things more youthful. And there's not a woman on the face of the earth that cannot take vaginal estrogen, even if they have active breast cancer.
Correct. Local estrogen does not have an effect on cancer.
It should be given out like candy, truly, to women 40 plus.
But when I had cancer, they said no.
That was just,
It was a long time ago.
well, they still say stuff like that, but that doesn't mean they're right. Medicine oftentimes is wrong.
But what you said earlier, and you just said it briefly, and it's one thing that I did want to come in and talk to you about, was HGH. Is that fallen out of favor now? Or is
We
that
use growth hormone releasing peptide. It goes beyond this meeting, but I think growth hormone is the most potent anti-aging product that exists. It's just we're not able to use HGH in the context of anti-aging anymore from the FDA. They black boxed it. But we use
Peptides.
releasing peptides like Simorlin
right?
all the time.
But I heard Smorlin is not like as effective.
It's not as
doing
effective.
The actual,
If you have access to your own HGH, I would use that. But I can't prescribe it.
No, I know, but there's that place by our house.
If you can find it.
Institute that does it there and everything. That I guess Suzanne Summers went there.
They're probably doing it on the download too.
They're probably what they're doing is they're a research facility, and if they are, that's how they're able to.
That's it. It kind of all of a sudden people are talking about it, and then it just fell off. Like they
Well, it fell off because the FDA does that.
Yeah, the FDA. It has a lot to do with the pharmaceutical companies, guys. Pharmaceutical companies don't want you to be able to utilize these things because they want to control everything that's delivered to patients.
They want you to be a consumer.
They want you to be sick. They want you to be sick.
Their stuff forever, but not the disease not kill you. Just keep you sick enough to be a consumer.
Correct.
If you're taking statins and blood pressure meds and antidepressants and anti-anxiety meds and insomnia meds and this, that, and another, and you're on a list like that long, like I used to see when people came to the ER, No, you're not dying from any of it, but you're on a full list. You're an active consumer.
Is that just American healthcare?
Yes.
That's what I thought.
Yes.
It is.
It's the American way. It's the American way. When people take control of their health, they start thinking these in terms of not being meds, but really more adjunctive therapy to prevent them from getting sick and having to fall into the whirlpool of chronic disease management and pharmaceutical cesspool. You start to see that you're coming out of the fog, because these things are ways to come out of the fog and not be subject to those types of treatments. And that's where I'm hoping that this industry, it's an unstoppable force at this point. We're still at an inflection point as a society as we're growing out of it, but the longevity movement is happening. Whether or not it applies to this room or the next room, it is happening, because the studies are irrefutable that these things are beneficial. They do prolong life. They do save you money, like not just a little bit of money. The cost savings associated with doing these kind of things is in the hundreds of thousands of dollars over a course of a lifetime.
I mean, yeah, that's what I would say. You're going to save. You think you're spending money for these things, but where you're saving is on being sick. And one of the things I'm going to say, because I don't know if John will say this, and I want to make sure I point this out. You don't like what Marshall Lifestyle Medicine offers is you can be a patient just in what we call like core, like that you're just coming to get blood work and do. You know, there's a lot of different levels of if you're interested, because John is rolling out a whole longevity package as well that I'm very excited about, because it incorporates a lot of these things beyond hormones, things that are, genetic testing, because you can change your epigenetics. And that's a fact. And so a lot of this testing will kind of give you baselines to help you know, even from a supplement standpoint, so that you're not taking, like I did, 60 supplements a day, that it can kind of help hone that in. And there's a membership for that too, because I do want to say that you can join, and it can be as simple as just working with.
Well, I just want to stop.
I know you're not.
I don't want this to have any.
It's not, but I'm just saying, because I'm passionate about this myself, and I'm very excited about it, so I'm mentioning it. It's not. He didn't ask me to do that.
On that then, because so Laura and I talked about this a lot. So I was gifted something from my parents when I turned 40 last year, and I go to Cincinnati, and I get testing galore, every single thing done. It's called the AIM Center, AIM, Dr. Moyle, and he's a fabulous doctor. It's so similar to you and Laura, and I just I go to him because it was gifted, and I go every year, and I just did all of my stuff. I have it sitting in my chart and all of my information. It went above hormones. I mean, I know what age my liver is compared to the age that my fingernails are. I mean, I know every single thing about my body, and I love it.
Yeah.
But I think it's amazing that you guys are going to create this, and I would like to stay local. Yeah. So I know you're not trying to do a sales pitch, but I mean, I'm here to tell you, I will come to you versus going there, because I like the fact that I can go 5 minutes, and I have to do a Zoom with him every 6 months. So
the reason that we do that is because our group has evolved over the years, and there's just so many fascinating things. I think people do best. Intelligent people do best when they know the cards they're holding.
Yeah. I know every single thing about my body.
So
I'm scared.
you know your bone density, and you know your family history, you know your epigenetic profile, and you know your blood work, and not just little blood work. When you know your ApoB and your Lipo-A and your... These are the kind of things that smart people do really well with metrics.
Yeah.
They do really well with them, because usually they run their lives with numbers, with other variables, and so it resonates with them. And it was my goal is to create a program that so people did not have to go to Mayo Clinic, Johns Hopkins, wherever you're going.
You can go to one facility.
And we could do it here in Lexington without having to and save for half the price.
Yeah.
And do it locally.